Happy National Immunization Awareness Month, everyone. Welcome to today's webinar, and thank you for joining us today. On behalf of the National Pharmacy Organizations appearing on the next slide, welcome to the All Pharmacy Town Hall, examining changes in vaccine policy affecting practice and community. I'm Mitch Rotholtz, and I have the honor of being your moderator for today's conversation. Our co-hosts that appear on this slide are organizations who are working together, and we are proud that the pharmacy profession is joining in one voice on vaccines. I do have a couple of housekeeping items to cover. Please download the handout with information from each of the co-host organizations via the GoToWebinar platform before the end of the session. And if you have any questions, enter your questions in the question field and throughout the session. So you don't have to do it at the end, you can do it throughout the session. And if time allows, we'll read your question and comments aloud for the panelists to react to. This presentation will be repeated tonight, August 6th at 7 p.m. Eastern Time. So for more than 40 years, I've worked across the profession and the immunization neighborhood to advance the public health role of pharmacists and public access to vaccinations. And so I am honored to be with you today as your moderator. Why are we doing this? In recent months, shifts in the ACIP vaccine recommendations and changes in the decision-making process have raised important questions across the entire healthcare system and public health. And with all these changes, it means, what do they mean for pharmacy and for public health? What do they mean for how you're going to interact with patients? What do they mean in terms of your compensation for your services? These are questions that have come up through the past several months and in the questions that we received from you when you registered for this conference. Today's town hall is designed to provide some forecasting and to spark some action. This is not your typical webinar, but it's an opportunity to engage, no matter what perspective you approach this issue with. The session will offer insights to help you with your understanding of the current state of vaccine delivery and help you educate your patients with confidence. We are really excited to have our outstanding panel of experts, and let me introduce you to each of them. Providing the national clinical perspective, we have Dr. Carolyn Bridges, a board-certified internal medicine physician who has worked in influenza and adult immunization issues for more than 28 years. She retired from the CDC in the role of Associate Director of Adult Immunizations. She is currently the Director of Adult Immunizations for the Immunize.org and co-chair of the National Adult and Influenza Immunization Summit, and she volunteers as a primary care physician at a local community health center. Thank you for being with us, Carolyn. Providing the practitioner perspective, we're glad to have with us Dr. Chichi Moma, a 2006 Temple University School of Pharmacy graduate. She started her career in the pharmaceutical industry, then managed the independent community pharmacy for 4 years before transitioning into opening her own pharmacy, Springfield Pharmacy, in 2012. In her practice, she administers vaccines across the lifespan, provides weight loss management services, in addition to a wide range of other clinical services. She is the first pharmacist in Pennsylvania enrolled in the Vaccine for Children's program. Welcome, Chi-Chi. And last but not least, providing a policy perspective, we're glad to have with us Dr. Brooklyn Morgan, the Director of State Policy at the National Alliance of State Pharmacy Associations. There, she leads the state-level policy initiatives to advance pharmacy practice and patient access to care. A licensed pharmacist with a background in health policy and legislative analysis, she supports state pharmacy associations in navigating complex regulatory and legislative environments. Brooklyn is passionate about empowering pharmacy professionals to better serve their communities through innovative and sustainable policy solutions. So together with our panelists, we'll explore the evolving landscape of vaccine guidance and the ripple effects on our work, our patients, and our communities. Hopefully, when time allows, we'll have time for questions because we really want to hear your vaccine concerns and your needs. The topics that we'll cover today actually came from the feedback we received when you registered for this conference. So thank you for all those that gave us what you are concerned about. So let's set the stage a little. Several major medical organizations filed a lawsuit in July against the Department of Health and Human Services and Secretary of HHS, Robert F. Kennedy Jr. That lawsuit challenged the unilateral dismissal of ACIP members, the COVID-19 vaccine policy changes, violation of federal law, and called for an injunction. The legal challenges and other activities that have been being undertaken underscore the concern about the erosion of evidence-based public health policy and the integrity of our federal advisory processes. And across healthcare professional organizations, efforts are underway to compile evidence-based, credible information to fill recommendation gaps and support practitioners in promoting and providing evidence-based vaccination services. The host organizations of this webinar are also working to support their members as they are serving the vaccination needs of the communities they serve. So let's get into our discussion for today. And there are a lot of moving parts in the process of vaccinations, and from the development of vaccines to ultimately getting them injected into a patient's arm. So Carolyn, what's the role of FDA and CDC within the process, and what and how do these decisions impact access and delivery of important vaccines?
Thank you, Mitch. Thanks for that question. This is a very complicated process, and there's a lot to unpack there, but I'm just going to hit the highlights for now. So the basic process is that, of course, manufacturers, particularly if they're looking at a new indication or a new vaccine altogether, they're going to develop those clinical trials along with FDA's approval for how those trials are conducted, what endpoints are going to be looked at. Once those trials are done, then FDA is going to review that information in detail. They often do their own, and maybe they always do their own separate analyses from the company. So you have really very independent review of the data. There are presentations, of course, on the vaccine safety is a huge issue, right? And of course, effectiveness. And that's presented to VRBPAC, which is their advisory committee to FDA on vaccines. And then VRBPAC, which is, a council, again, of experts in immunizations and conducting clinical trials and statisticians and so forth, then they would make a recommendation and present that to FDA. Then FDA itself would make their own recommendation based on the advice of VRBPAC, considering VRBPAC's advice. Once a vaccine is then licensed, then the uses of that vaccine and considerations for vaccine recommendations are considered by the Advisory Committee on Immunization Practices, so ACIP. So ACIP is a different group of experts in immunization. It includes clinical experts, people expert on vaccine effectiveness, cost effectiveness, clinical trials, vaccine safety, etc. And there's always has been a person from the community representing community interests on ACIP. So they'll also review the data. They'll look at additional things in addition to what FDA looks at. That they'll also look at cost effectiveness, things like numbers needed to treat, the epidemiology of the disease, who's at greatest risk, who's likely to have the greatest benefit of getting that vaccine, and the relative risks and benefits. So the processes that ACIP has used to make those recommendations are GRADE. So that's a very transparent way to methodologically go through the data, make sure you're not cherry picking data, that you look at data quality, you rank studies and the strength of data based on study characteristics and potential for bias. And then they use another guidance called Evidence to Recommendations Framework for ACIP, the Advisory Committee on Immunization Practices, then to make a recommendation about who that vaccine, which groups are best for use of that vaccine, again, considering that risk balance. And then that recommendation from ACIP has gone to the CDC director for making recommendations. So these decisions made by FDA and CDC with input from their advisory committees then impact the availability of vaccines and vaccine access, and then also impact vaccine payment. So are insurers, payers going to cover vaccines, and for which groups? So those are just the highlights.
Thank you, Carolyn. Thank you for condensing it so that we get set the stage for our discussion today. So I'm going to turn to Chi-Chi a second. And as an immunizing pharmacist, but also a broader patient care provider, how do recommendations from ACIP and other entities impact your practice? And what resources do you use to help you make clinical decisions and recommendations?
That's a good question, Mitch. It's crazy because the last couple of years, there has been a lot of changes, right? And even during the pandemic, we always have to pay attention for when the ACIP is meeting and what's the next recommendation, what is changing. So we have to always put our finger on the pulse. And even with these changes with ACIP, CDC, and HHS, I think it's important to recall that professional medical societies routinely make clinical guidance. Their recommendations are based on expert review of the medical literature, and that all healthcare providers rely on these expert reviews, right? So what is the ACIP talking about right now? What's the CDC talking about right now? And we need to know what is happening today, not last month, for us to be able to make clinical decisions for our patients. And like you said, we do serve a broader range of patients, from pediatrics all the way to geriatrics, right? And examples we use in our practice include guidelines from the American Diabetes Association, right? So if I'm dealing with a patient that falls underneath this criteria, how do I serve this patient better? American College of Cardiology, American Heart Association, and there are many others, right? And these clinical guidances may be done in collaboration by 2 or more professional societies, or maybe by one single society, and it's patient by patient basis. But we need to understand broadly what is ACIP saying and what is CDC saying, and their accepted guidance on how to conduct scientific reviews for developing trustworthy clinical guidance, right? And one of those methods that is widely used is the GRADE method. And I know we're going to talk about this later on during this forum, but the AAP has also been issuing recommendations for years. Even the Academy of Family Physicians, I've been in a lot of immunization meetings or immunizer meetings where we are talking to pediatricians, we're talking to physicians, pharmacists are there, everybody's just bringing their thoughts together to figure out how can we make the guidelines better for individual patients, right? And Infectious Disease Society of America, what they endorsing ACIP recommendation, and also APHA endorsing the adult immunization schedule. So depending on the patient base that you serve and depending on what their disease state is, these things are what help us make a decision on how to serve our patients better. So with the changes of the ACIP, you ask the question, how is it impacting my practice? We just have to figure out, what does my patient need today? Because it's completely different from what they needed yesterday.
Thanks, Chi-Chi. We'll come back and talk about some of the issues you touched on. But I'll ask the panelists, and the audience may have heard pieces in the media about an activity that's going on from the Vaccine Integrity Program. What is that, and what is that going to mean for practitioners? How's that going to help practitioners? Who wants to touch that, Carolyn?
Sorry, I'm challenged with the unmute yet. I think that there's a lot of information that I believe you already put the link to Vaccine Integrity Project on there, but they have a lot of great information on their website about what they're doing and what they're and how they're doing it in terms of trying to bring groups together to have recommendations available for particularly for the fall immunization vaccines. So we just saw that maybe it's been a week or so ago that on the CDC webpage, there is now the announcement about the HHS is recommending annual flu vaccination for everyone 6 months and older, but they recommend not using multi-dose vials, for example. We know with COVID-19 vaccines, there are big differences in terms of now what HHS is recommending regarding groups for COVID-19 and vaccination recommendations from the professional societies, including APHA, AAFP, ACP, ACOG, et cetera. So this, you're asking how is this impacting our clinical practice? I can tell you with the patients that I see and even the providers, people are extremely confused about these differing recommendations, and that makes it much more difficult, I think, for providers to try and explain why there may be these differences, and but as Chichi just said, we have to just keep making sure they are getting the recommendations for them specifically based on their own circumstances. So what we're hoping from the Vaccine Integrity Project is again some more helpful guidance and review of the literature in a transparent way that will help providers then be able to make evidence-based recommendations for their patients.
Thanks, Carolyn.
And I do agree with Carolyn, because it's not just about the facts, right? It's about restoring confidence in the systems behind those facts, and restoring confidence in the healthcare providers so that we can turn around and restore confidence in the patients that we serve. Because the goal here is to boost vaccine confidence among healthcare workers so that healthcare workers can go out there and educate our patients and be able to tailor our services to meet their challenges.
Okay, so we're going to come back and talk about that hopefully before the end of this, because as you all may have heard, we've got some new information that also comes out and makes our jobs a little more challenging. We'll come back and talk about that, but I want to turn to Brooklyn. And one of the things that a lot of pharmacists and pharmacy teams are concerned about is how do the recommendations from ACIP and CDC and FDA impact pharmacists' authority to administer vaccines. Could you give us a little insight of that impact and what the concerns are?
Absolutely. Great question. So unlike other health professions that typically follow more of a standard of care approach, pharmacists' authority to prescribe and administer vaccines is shaped by a combination of those federal guidances from ACIP, CDC, and FDA, and state level laws and rules that incorporate those federal guidances by reference. So whether it's in laws, regulations, statewide standing orders, Board of Pharmacy protocols, et cetera, the overwhelming majority of states tie a pharmacist's ability to vaccinate directly to either CDC or ACIP. In the past, this methodology has been leveraged as a tool to help immediately expand pharmacist authorities without the need for legislative or regulatory changes, since we know a lot of times those things can be slow moving and is often outpaced by innovation in science. But with the recent changes to ACIP and our uncertainty about potential future changes that might happen, there's been a lot of concern raised about this volatility and how it could potentially delay or inhibit a pharmacist's ability to vaccinate their patients.
Okay, thank you, Brooklyn. And one of the things that we hear a lot from pharmacists about is concern about coverage and payment, and the impact that not having an ACIP recommendation would have on that ability to bill and get paid for it. Any insights you could share on what's going on and trying to address that? And I'll have you start, and then if one of the other panelists want to add, we can have them do that.
Sure. So to start with a little bit of background information here, As most of you probably know, the Affordable Care Act requires that most private insurers and Medicaid programs cover vaccines that are recommended by ACIP with no cost sharing. So this means that anytime ACIP adds a vaccine to its schedule, it automatically becomes free for patients who are eligible. Additionally, the CARES Act specifically mandates rapid coverage of COVID-19 vaccines that are recommended by ACIP. And insurers must cover those within 15 business days of the ACIP's adoption, even if it's not for routine use. So with those all being tied to, again, ACIP recommendations, changes to ACIP could lead to vaccines not qualifying for that mandatory coverage and leading to increased patient cost sharing or lack of reimbursement for pharmacies. So while pharmacists may potentially retain the ability to provide the vaccines to their patients, barriers like higher costs for patients or lack of reimbursement could prevent the most vulnerable patient populations from actually being able to access these services. I will share something a bit more positive. We have gotten indications from payers that there's a willingness to utilize things like evidence-based data when making coverage decisions. But those are still a work in progress, and dialogue will have to continue, but hopefully it's positive news.
It's always good to have something positive in this environment, so thank you for sharing that.
Yes.
And Carolyn or Chichi, anything to add?
Yeah, just to say that, you know, the ACIP recommendations, as you say, really do impact access and payment. And yeah, I'm really grateful for the payers who have come forward and really said that they're going to continue to support immunization payments, but it is going to make it more complicated for providers potentially. And I guess one, you know, recommendation is if you have, you know, some big providers that you typically, or payers that you work with, to reach out to them and make sure you have a strong and firm plan about what their payments are going to be like, so we can make sure and let our patients know that. You know, vaccines save lives, they prevent hospitalizations, they prevent long-term disability. That has not changed. I think it's important for us to remember that the science hasn't changed, and we need to continue to go with the science and what we know works for our patients, and to try and keep them healthy.
Okay, thanks, Carolyn. Okay, Brooklyn, just to follow up on what you had covered, if changes are not made to the ACIP recommendations, what can pharmacists do to sustain the public's availability and accessibility to needed vaccines from pharmacy?
Yeah, so to help prevent gaps in care, your state pharmacy associations are already proactively working in collaboration with boards of pharmacy, departments of health, and other public health entities to help address these concerns. And we have equipped your state pharmacy associations with resources like draft executive orders for kind of immediate action and bridging coverage gaps or scope of practice gaps, as well as additional advocacy tools such as template letters to legislators and other things for more long-term solutions. So certainly as an individual, get involved in those conversations through your state pharmacy association. If you have questions about changes in authorities, reach out to your board of pharmacy or legislators to make those changes.
Okay, so there's a question in here that we'll get to later, but actually let's cover it right now. It relates to the PrEP Act. Does that authority still exist?
Yes, so I'm sorry, I'm reading the question here. So each state can interpret the PrEP Act authorities how they would like to. Currently, pharmacists are able to vaccinate with the PrEP Act, but you know, refer to your state, reach out to your board of pharmacy if you have more questions.
Okay, thank you, Brooklyn. Chichi, turn to you a second. You are a vaccine for children's provider. How does the ACIP lack of recommendations impact access for the VFC program? let me word it this way. As a VFC provider, are you concerned about the lack of ACIP recommendations and what impact that might have on your ability to provide vaccine for children vaccines?
I believe Chi-Chi might be on mute. I don't know if someone can help her get off mute.
Okay, we'll move on until we get the technology.
I'm here.
Okay,
So yes, thank you for the question. Technology sometimes goes crazy, right? Your question about my VFC program, the VFC program does depend on the ACIP, right? A vote to include vaccines in the VFC program are also made by the ACIP, and if ACIP approves a vaccine to be included in the VFC program, yay. But if they don't, what does that mean? Especially for the special population that I serve, right? And the VFC does provide about half of all the vaccines for United States children who are eligible based on either being uninsured, underinsured, or they have Medicaid, Alaska Natives or Native Americans. So there's criteria to qualify for a VFC program. And if a ACIP votes that these vaccines can be in the program and then the CDC director approves it, then we're golden. But am I a little worried about some of the changes in the ACIP recommendations? Is it going to trigger that the VFC vaccine list will change, and will it affect our supply or procurement of the vaccine? I am a little worried. That's why we always have to stay alert to understand what is actually happening with all these meetings, right? With the ACIP and the approval process, because if it's approved and it ends up on the list, these are free vaccines to the children that are eligible, that qualify to get it.
Okay, thanks, Chi-Chi. So we're gonna transition to, we're talking a lot about the ACIP meetings and what changed. So ask Carolyn start is how was the recent ACIP meeting different from those that were held in the past, and what insights coming out of that meeting did we glean about the future direction of ACIP and vaccine policy in the US? And maybe Carolyn, when you touched on that, maybe you could also touch on what was announced yesterday about the mRNA vaccine research money going away.
Thanks much. I wish I had a crystal ball, but I don't. I can just tell you, what has changed more recently is, as I think everybody knows, the sitting ACIP was replaced. All the 17 members were replaced with other members who, by and large, have less experience with immunizations, fewer publications, and a smaller number of those members. Some have been vocal vaccine skeptics. Now, we should all be vaccine skeptics at some level, right? We know that vaccine safety is incredibly important, but we want to follow the science. Safety is, number one. But we want to use a process where vaccine safety evaluations are done in a very systematic, unbiased, transparent way. And what did happen was bringing back discussion about thimerosal and influenza vaccines. It has been removed from all vaccines except for multi-dose vials for flu vaccine. And without, again, a reworking of that decision, the use of typical accepted good practices like using GRADE and evidence to recommendations, that decision was made by the ACIP without that process and just based on a single presentation of one individual. So that process did not go through the typical way that we expect for CDC's ACIP to work, which is using GRADE and evidence to recommendations framework. So I think that's very concerning. What we do also note is that the process is also less transparent. So to make clinical guidance that is trustworthy, transparency is key, and following accepted scientific processes for the appropriate review of science and the strengths and weaknesses of studies, being transparent about which studies are included and which are excluded from the analysis. Those are all really important factors in how scientific clinical guidance that is evidence-based should be made. So the fact that it wasn't followed in that instance, is concerning.
Thanks, Carolyn. And so let's follow up on that too, because one of the questions that keep coming in from the audience is, for this upcoming respiratory virus season, what are the vaccines that are recommended to be administered and to whom? So boiling down what came out of that ACIP meeting, what do pharmacists need to know in terms of the upcoming respiratory season?
Is that question for me, Mitch? So I think for the upcoming season, again, we do anticipate, based on what Vaccine Integrity Project has said, that they will be having some additional information that that can be shared. We also, do have a recommendation from CDC for routine vaccination for everyone 6 months of age and older for influenza vaccine. The difference between what ACIP is saying and what the professional medical societies and APHA are saying is about thimerosal. Even on CDC's webpage, it says that the harms from thimerosal are limited to, greater, local reactogenicity, maybe a sore arm and redness at the injection site. But still, 6 months and older, we don't think that recommendation is going to impact substantially the influenza vaccine supply. So we should proceed with influenza vaccination as we have always done. And again, the epidemiology and impact of influenza has not changed. So we know every year it's an issue. RSV recommendations for the vaccine, for this year, we have a recommendation down to age 50 for high-risk people and everyone 75 and older. There's no change to the vaccine recommendation for RSV vaccination of pregnant women. That is still in place. And we now have 2 monoclonals for infants against RSV. And that second monoclonal was approved by the ACIP at their more recent meetings. So we have that for RSV. For COVID-19, I think this is where we have some of the most discrepancies between what HHS is now saying and what the professional societies are saying. So I hope we can put in the chat so people can find those links to APHA's guidance, AAFP, American College of Physicians, and American College of Obstetricians and Gynecologists. So I would really recommend people, follow very closely their professional societies, who are really, going to be some of the best people to make clinical, recommendations for your patients based on best practices for your profession. So look to those. But again, epidemiology hasn't changed. We still know that COVID-19 is circulating. It still causes severe disease, particularly in older adults and people with high-risk conditions and pregnant women. So I would follow your professional societies there.
Okay. In terms of, I've just got a question here, is how should pharmacists respond to the shutdown of the mRNA funding research and the statement from the secretary about going to a whole virus versus what we have today, which is components of a virus in the vaccines, and the misinformation that's being stated about mRNA. So one of the challenges that providers are going to have is having that discussion with patients who are now going to be even more reluctant to get an mRNA vaccine. How do the panelists recommend that the listeners of this respond and work with their patients on educating them?
I would recommend that you leverage your professional associations, whether it be your state pharmacy association or the national organizations like APHA and others. They are putting out great resources on how to improve vaccine confidence and really address those concerns with patients, as well as being able to have your voice heard at a national level and voice those concerns to the policymakers.
Okay, thanks, Brooklyn.
And I also say, like, we have to make the patients feel heard, right? Not dismiss what they're telling us or their fears, but acknowledging them first and then backing it up with science and reminding them what these vaccines have done for us, right? And reminding them that science been helping us and there's evidence that it has. And just remembering also our position in the communities, at least for where I'm standing, that they see us as trusted voices, right? Making them feel like we're not pushing our agendas on them, but we are stating facts. And I hear you. However, this is what's good for you.
Yeah, I agree with you, Gigi. I think that's really important to acknowledge to patients that I understand that this is really a confusing time. We're all hearing very mixed messages. This is what my professional society is saying. I've also looked at that evidence, and clearly these vaccines have worked and they've had significant impact in preventing severe complications. We know that from, placebo-controlled trials. We know that from observational studies that have happened every single year since those vaccines became available. I get vaccinated myself. I recommend my family gets vaccinated as well. Those kinds of reassurances, but also, as you say, really importantly to be backed up by science, are very helpful. And then making sure, as you say, to tailor that message to that specific person. Carolyn, you have asthma. You're at higher risk, or this is why this is maybe particularly important for you, given your age or the fact that you have coronary artery disease or whatever it happens to be. Making sure to tailor that message can also be, I think, very helpful to people. But acknowledging the confusion that's been caused, I think, is really, really important. And then pointing back to, here's what other pharmacists are saying. Here's what physician groups are saying. And pointing out who you trust. This is who I trust to get my information from.
So we're going to come back to that in a second, but there's a question that came in terms of I've got the current COVID vaccine in stock. Do I administer it, or what do I do?
Well, if you look at the current interim clinical guidance on the CDC website, it's pretty clear that they're still saying the same thing, which is, someone wants to get their COVID-19 vaccine now, and you have the 24-25 formulation, and we're not sure exactly when the next 25-26 is going to be coming out. I'm going on a cruise with my 90-year-old mother. I want to make sure I'm vaccinated. Great, go ahead and give, obviously unexpired, vaccine that you have on hand, and then people can get the updated vaccine. You need to wait 2 months to give the next one. Just make sure you have that interval, but perfectly acceptable for people that want to, be protected sooner rather than later. And then they can come back, after 2 months once the updated vaccine is available and get that next.
And for Mitch, what I told my team, the script that we use is we currently offer the 2024-25 COVID vaccine, which ACIP recommends for everyone. to get. But if there's an updated vaccine that becomes available later on in the season and ACIP formally includes it, right, we will definitely offer it at that time. But until then, this is the standard of care.
Yeah. Great responses. Thank you, guys. So following up, we were talking a lot about evidence-based data. So how does a pharmacist or a team member know that they're looking at quality evidence-based? How do you determine whether it's credible or not?
That's a great question, Mitch. I think first you want to look at the source, and you want to be clear about the methods that were used. That is really important. When people speak in terms of anecdotes or cherry pick studies, that should be a real red flag that there's a problem there. So appropriately designed reviews will include a thorough look at the literature that's available. They will weight information differently based on a randomized trial versus an observational study versus a case report. And that really helps with decision making and is really an essential process to go through to make sure you're coming to the right conclusion or the most evidence-based conclusion that you can. So your source and then the methods. And then really make sure when people are talking that they're not just pulling out, study A or study B, because that's the one that supports my personal viewpoint, but they are able to look at the data as a whole, weighted based on the strength of the evidence, and that they're transparent about what was and was not included in that analysis. So those are the kinds of things I think that they should look for. And the National Adult Influenza Immunization Summit has a nice sort of cheat sheet summary of what to think about when you're thinking about evidence, strength of evidence, and development of clinical guidelines.
And also, I want to know those one-sided studies out there, right? I also want to know what's in there because I want to be prepared to have a good conversation, whether it's with a healthcare provider or a patient that is so sold for that one-sided study. I want to know what they know so that I know how to educate them better, right? So I want to know everything that is out there. And then as a pharmacist, like Caroline said, realizing which one is not fake news, right? Which one is good data for me, but also I want to know everything out there so that I can help different views.
Okay, great responses and recommendations. In relation to that, from the very beginning of vaccine time, we've had discussions between patients and their caregivers and their healthcare providers regarding the benefits and risks of vaccinations. And the term shared clinical decision making has made its way into discussions and policies and recommendations. Can you boil down for us, simplify for us, when shared clinical decision making, what is it, and how does it impact pharmacists and other healthcare providers' ability to deliver immunization services? Who wants to touch on that?
You want to take that, Chi-Chi? You want me to start?
You can start.
Okay. I mean, really, shared clinical decision making occurs when, maybe there some very individual considerations that need to be taken into account with regard to an immunization. So let's say it's not maybe appropriate for everybody 50 to 64, but there are certain groups within there based on their individual circumstances that it may make it more appropriate for them to get vaccinated. They may see bigger benefit based on their individual circumstances. So that's what makes it a little bit different from a universal recommendation, such as, everybody should get a TD or Tdap vaccine every 10 years versus, gosh, you're 40, should you get an HPV vaccine? That may depend really on your individual circumstances in your life. They should all be covered, whether it's an individual shared clinical decision-making recommendation. That's still a recommendation, but we do know that in some cases it's more challenging to get vaccines paid for when they are based on high-risk circumstances. So they should be, but it can be challenging, and sometimes you have to, educate your payers. So teaching.
I love how you said it should be covered, right? Because that's the challenge that we face here. We do have some shared clinical decision-making moments with our providers, whether it's a patient with cancer that needs an additional dose, or there's so many things out there where we have to, a provider and us, we decide, okay, this is what's best for this patient. And then it doesn't get covered because it doesn't fit that mold, right? And you can peer review it all you want and it's still not covered. And then what happens then? And this kind of deters some providers from actually making those critical clinical decisions that is best for that patient at that time. But there are always ways around them. But then how many providers want to keep doing that and keep hitting that wall? But the good news, based on the question that Mitch did ask us, is do we see that in our practice? Absolutely. And it gets me excited because this is where physicians and pharmacists put heads together to figure out what is best for the patient.
Yeah, I would also add from more of a policy perspective there, this may look different state to state on exactly how pharmacists can, do these services, and pay special attention to the documentation requirements and other things that may be necessary in order for you to get that payment.
Great points from all the panelists. And one thing that I want to add is that the who's eligible to do shared clinical decision making, pharmacists are a provider. So don't think that you have to ask a physician for approval. You are a provider who could do shared clinical decision making. So as Carolyn said, having that discussion with patients have been going on from the beginning of time. And so you are eligible for doing shared clinical decision making, and keep that focus. All right, so good. Since we mentioned payers, we got a question in the chat, and Brooklyn, I'll start with you on this, is how can we determine an insurer's willingness to support with evidence-based resources? Should pharmacies be prepared to submit certain evidence for rejected claims? And do you foresee a new pathway for vaccine coverage determination?
Great question. So one of the things that we have been working on, those proactive approaches that I mentioned before, is having a letter for the state pharmacy associations to send out and request that all of these payers proactively commit to using evidence-based data to continue to cover these. We have, gotten some positive responses, as I mentioned before, but that's something that we're going to continue to do and are working actively on that. So hopefully that is, an area that we can get a little bit more clarity on in the coming, weeks and months. But it is important that, you mentioned saving rejected claims and things like that. Absolutely. Be as proactive as you can in documenting all of those things.
Does anybody have anything else to add to that? Okay, another question that came in is, do we have any insight into when the 25-26 COVID-19 vaccine will be available? Carolyn, pull out that crystal ball.
Yeah, I wish I had that crystal ball. I don't have that. What I've heard, now I'm going into rumor and innuendo, is that there is likely to be an additional ACIP meeting. There's an ACIP meeting that is currently scheduled based on the website on October 22nd, 23rd. Of course, that's kind of late in the season regarding COVID, but I believe there's also consideration for having a separate ACIP meeting sometime end of August, early September. So that may be when we'll hear more from ACIP.
Okay, Another question that came in, if state regulations are ACIP recommended, will COVID vaccine still be covered if there is no ACIP recommendation for general population?
Can you say that again, Mitch?
So if the state regulations require ACIP recommendations for pharmacists to be able to administer COVID vaccine, will it still be covered if there is no ACIP recommendation for general population? So from a legal regulatory perspective, as well as from a payer perspective, how not having that ACIP recommendation. We covered it earlier, but let's reinforce what we had talked about.
Yeah, so I think there's kind of two sides of this. So the first half of the question is more about the pharmacist's ability to actually administer vaccines. If the regulations tie a pharmacist's ability to either prescribe or administer a vaccine, there is a great possibility that that ability would no longer, be in effect. We are, again, proactively working to put things in place to help bridge those gaps if it is to be an issue. So on the authority side, there's a great potential that that could be removed. On the payer side, I think it's important to differentiate between mandatory coverage and just general coverage. So although most of the coverage mandates are tied to ACIP, that's just the mandates, and a payer could choose to still cover it based on evidence-based data.
Okay, anybody have anything else to add to that? Okay, so here's another question that came in, which is a really good question, is how should pharmacists interpret opposing recommendations from different recommending bodies? And Carolyn, maybe you can touch on, from the historical perspective, we had AAP and ACIP doing recommendations.
Yeah, thanks. That's a great question. Yeah, so as you mentioned, the American Academy of Pediatrics, they have been reviewing the pediatric schedule and making recommendations about the pediatric schedule for decades. And there have been instances where the ACIP and AAP have not been aligned, although major efforts have been made to harmonize those schedules. It makes it certainly a lot easier on the medical, pharmacy, nursing community, the public, when there's a single unified voice. But there have been instances where we don't see that. There are differences in organizations regarding, for example, prostate cancer screening guidelines as well. So it's not unprecedented that different organizations have professional organizations, clinical guidance developing bodies have somewhat different recommendations. So, I think really who is the most trusted source of information for you as a clinician, as a provider of immunizations in your community? Who is that most trusted source for you that you're going to rely on for making recommendations for the care and health of your patients? So I would, really encourage people to, as I think you already all do, really follow what American Pharmacists Association is doing, what AAP is saying about pediatrics, what ACOG says about vaccination of pregnant women. So that would be my suggestion. But as Brooklyn has pointed out, this not harmonized recommendations can and may cause, first of all, a lot of confusion and uncertainty about coverage and about authorities, for some pharmacists to administer. But in terms of what is trustworthy guidance, I suggest at this point that we all look at our professional societies for that and really consider what was the basis of the decision making that led to those recommendations not to be harmonized.
So a couple of questions have been coming in around the whole, do you not follow ACIP guidelines versus professional organization guidelines? And so, Carolyn, thank you for providing the pathway you just talked about, but let's use an example. So questions have been coming in about pregnant patients. Pharmacists who have the authority right now to administer to pregnant patients, how do they handle it when there's a gap in the ACIP recommendation?
Well, I think that's something you need to talk to your patients about. Consider what the payers are saying. Make sure the patient's informed. But really, the expert people on the care of pregnant women is ACOG. They are the clinicians that care for pregnant women, know and have seen what those complications are for pregnant women and their babies. And they have been pretty clear already on what their guidance is. So the payment issue, as Brooklyn has talked about, and as Chi-Chi has talked about, that's a question. And so I think reaching out to your state pharmacy association, the payers that you work with, it's helpful, groundwork to do in advance. And so the patients are informed about what their out-of-pocket costs may be based on the recommendations that you make as a clinician who's caring for, providing the medical evidence-based care for that patient.
So the last question that we'll ask the panelists, and thank you all for the great insights you're providing, and the audience for the questions that you're submitting. What's the one pearl you could give our audience for how do you communicate these changes that are going on and the skepticism that is developing among the public? What's the one pearl of advice you can give the audience of having that conversation?
Well, I guess, the patients are going to come to you. They came to you. They've already come to you and said, "You're my physician. You're my pharmacist. What do you recommend for me?" And so, again, share your personal information about what you know about the evidence-based recommendations and guidance, and why you would or would not, in some cases, potentially recommend a certain vaccine for your patient, given their individual circumstances. But I think transparency, clarity, and expressing, your concern for their individual well-being. That's why they're coming to you in the first place.
Okay, thank you, Carolyn. Brooklyn or Chi-Chi, anything?
Yeah, I would just add, I think what Carolyn said is great. Also, I would just remind everyone that you are medication experts. You are highly trained and skilled in this area. So approach these conversations with confidence and utilize those skills in encouraging your patients to make the right decisions.
Okay.
And I also say to my peers, remembering that healthcare is not a one-size-fits-all, right? And having that in the back of your mind when you are educating or counseling a patient really matters. And yes, ACIP and AAP might not be on the same page at the moment, but if you're dealing with a pediatric patient, what does AAP say for this patient? And this patient might have multiple layers, might be immunocompromised, right? So it's not a one-size-fits-all. And you have this patient in front of you right now, they trust you, and you're going to help them make the right clinical decision for them with the information that you have in this moment, and be confident doing it, like Brooklyn said.
Thank you, Chi-Chi. Thank you, Dr. Bridges. Thank you, Dr. Moma. Thank you, Dr. Morgan, for sharing your great insights with us today. To our webinar participants, on behalf of the National Pharmacy Associations, who are working together to follow, analyze, respond to, develop guidance that will help you and your pharmacy teams do well public health-wise for your communities and the patients you serve. We appreciate your interest and participation in today's webinar and hope that you gain some insights that you can use as you move forward this coming season and beyond. Please download the handout for more information on how organizations are supporting you and your vaccine efforts. And thank you for attending. Please share any questions with your National Pharmacy Organization as they continue to collaborate and coordinate on behalf of their members. This concludes today's webinar. Thank you for joining us. and thank you for everything you do every day. Be well.